stand by. We are about to begin. Good day and welcome to the McKesson Corporation Patient-Centered Medical Home DeMystified conference call. Today's conference is being recorded. At this time, I'd like to turn the conference over to Mr. Tim Caver. Please go ahead, sir.
Good afternoon, everyone. This is Tim Caver, Vice President of McKesson Practice Care. McKesson Practice Care is a new services offering from McKesson that was designed specifically for the small independent primary care practice. We launched it in September of 2011 at the American Academy of Family Practice to really strong and positive reviews. What I'd like to do today is to briefly walk you through some of the rationale behind why we're doing this and why this is so important to us as well as so important to our customers, to you. Afterwards, I'm going to introduce our guest speakers for today, Dr. Sue Andrews and Dr. Rickard of Family Practice Partners in Murfreesboro, Tennessee. We're going to walk you through their experience with going from a traditional primary care to a patient-centered medical home. So first, let me just talk through why the practice care model and why the focus of McKesson on this particular segment. Well, the first thing you should know is that an overwhelming majority of our customers today are small independent primary care practices. And we've done extensive research over the past 3 years on understanding what are some of the unique challenges facing the primary care physician and how can we help. And what we learned is that there are several issues that are facing physician practices today, specifically that group that I mentioned. One, there's a revenue and cash flow problem. The other is sort of operational efficiency. Others are concerns around sort of their time and quality of life. And then lastly, around having a voice. So just to point through a couple of those specific challenges, in the upper left-hand side of this slide, you see a graphic that shows that the average family medicine physician earns only about 53% of the average specialist physician. When you actually go to the MGMA physician statistics for 2011, you can see that the average actual net income for a family doctor is actually lower than what you see here. It's closer to $170,000, and that's significantly less than some of their counterparts. On the bottom side, you see that there is a deep concern around upcoming physician shortages. This supply and demand gap that you see that shows a gap between the available number of primary care physicians versus the amount of patients that are needed to be served is already significant, but this was before the Affordable Care Act made it possible for an additional 34 million Americans to afford health care insurance in the next few years. So the gap that you see there is just going to get bigger and bigger. So from the provider point of view, physicians prefer to remain independent. In fact, in the research that we've done over the past 2 years, we found that 80% of independent practices would prefer to remain independent rather than selling to a larger group or to a hospital. But at the same time, they lack viable options. So you have seen a trend of about 4% or so per year, small practices being sold to larger groups and hospitals. But the status quo will no longer do it. As I've mentioned, there's a supply gap that's only going to get bigger over the next few years. And so providers want to be able to deliver care, but do it in a way that is more satisfying and rewarding financially and also sort of socially as well, or psychologically as well. And they said, when we've summarized their needs, they said we need to have more time and we'd like to be able to make more money. The health plans in the U.S. as well as in the government are asking themselves, why have they let primary care get to where it is? In a Wall Street Journal article in January of this year, this graphic on the left was shown. It shows how Medicare spending was allocated in 2010. And what you can see is that only 2.8% of Medicare spending was spent on primary care doctors. And essentially it pointed out that our system is somewhat upside down. We are not rewarding the people who have primary responsibility for sort of navigating patients through the healthcare system and being the quarterback of care for all the various disease states that they manage. And especially when you consider there's a shortage, this income gap and this reimbursement model is driving medical students away from primary care. So the payer bottom line is that they would prefer to see primary care physicians remain independent. They believe that additional employment by hospitals of physician practices is a conflict of interest. The reason is that the hospitals are looking to lock down referral bases of physicians to drive patients into the hospital, where it's been documented that there is a lot of unnecessary procedures, unnecessary ER visits, unnecessary admissions, and those drive our costs up. So payers do not want primary care to be as is. They would like to see them brought into the patient-centered medical home model, so we can start to see the value that a primary care physician can actually generate in terms of improving overall healthcare quality and reducing healthcare costs. They are willing to spend in both incentives to the physicians as well as in infrastructure and technology, but there is a concern that practices can't do this by themselves, and so I'd like to talk more about that in just a minute. Here's a couple of examples of payers or health plans who have actually gone from pilot phase to full implementation. And as many of you know, there are already many pilots around the country where they've demonstrated the patient-centered medical home model works when you provide incentives to primary care physicians. It's lowering costs and improving care quality and reducing all the unnecessary procedures and admissions that I've talked about. Well, WellPoint, in that same Wall Street Journal article in January, stepped up significantly. They made an announcement that they are going to recommend the patient-centered medical home model to all of their primary care providers nationally. And they're willing to step up with an investment of $1 billion, both in incentives and in infrastructure for those physicians. They represent 32 million covered lives, which is the largest private paying organization in the U.S. Their goal is to create high-performing patient-centered medical home networks. Another example is Independence Blue Cross in Philadelphia, Pennsylvania. They've made a $32 million investment in infrastructure and incentives. So today, what each of these groups are doing are saying, we believe that primary care physicians can drive the care up and the cost down, but we need to first provide them with a model, and that model is the patient-centered medical home. And there are many governing bodies or recognizing bodies for physicians to use to figure out how to structure themselves and position themselves to get those early incentives. But beyond that, what these payers are looking for is for the actual performance. And so we're sort of in that first phase right now, which is there's money on the table that's been untapped, and if the physicians will recognize the opportunity by adopting the patient-centered medical home model, it's the first step. But over time, if you learn how to do it through a process, so that it's not just checking the box, but you're actually redesigning and reorganizing your practice to deliver on results, then you'll be able to a better fit for these evolving healthcare models as we move forward. So for my last slide, before I turn it over, the last two slides before I turn it over, we summarized all of our research on physicians wanting to remain independent and their top challenges. And I won't go through all of those details here, but the high-level summary of the needs were physicians wanted a solution that allows them to generate enough revenues and control costs to restore healthy profit and provider income levels, just the way things used to be from a financial standpoint. But they also need a solution that will show them how to perform optimally to improve clinical care quality, because again, the payers are going to want to see performance, not just that you can check the box, but they want to see the actual reductions and improvements. And then lastly, physicians need a way to position themselves to participate in these future healthcare models and incentive programs. The two that I mentioned are just a couple of examples, but there are many other significant initiatives underway probably the most significant is the Comprehensive Primary Care Initiative that was announced in October by CMS. What CMS is doing is they are structuring a model where multiple payers in a given region will come together to put to structure an incentive program for the primary care physicians in their region. That way, it's not just one payer providing incentives, because only one payer typically represents maybe 20 to 30% of the patient population. But when they all band together and they structure their incentive program similarly, it makes it easier for a physician to adopt the model. It makes it more attractive. But anyway, the 5 pilots from that program will each receive additional incentives from CMS directly to the family practice doctors or primary care doctors for Medicare and Medicaid patients, in addition to the private payer incentives. So our solution to all of those things is McKesson Practice Care. What you see around this list is a series or a suite of different solutions, all aimed at improving financial, operational, and clinical performance within the small independent primary practice, all designed to work around McKesson's EMR platforms, whether it's Practice Partner or Lytech MD or Medisoft Clinical. And each of the tools that you see there are designed to help solve for some of those challenges that we mentioned. Just a few examples are MD Collect, which is a patient collections tool, because that's very difficult for practices to collect from patients once they walk out the door. And now the patient responsibility is becoming a bigger challenge because patients are now responsible for a higher percentage of their overall bill. Allpoint is a tool that allows you to send automated reminders either through SMS text, email, or phone to patients to reduce no-shows, because when the patients don't come in with the current fee-for-service model, physicians don't get paid. And then Link's Total View is a reporting tool that allows you to identify gaps between your contracted rate or fee schedule with your payer and what you're actually getting reimbursed. And that simple reporting tool allows you to drill down and actually identify denials specifically, and you can then go back and collect some of those dollars that you might have missed otherwise. But the focus of today's discussion is really on the clinical side. And to talk about that, I've invited Dr. Susan Andrews and Dr. Randy Rickard. They're 2 family practice physicians that work together in a 4-provider practice in Murfreesboro, Tennessee. They are long-term and what we consider super users of McKesson Practice Partner software, but they've gone through this transformation already, and I'd love for them to tell you their story.
Well, thanks, Tim. I hope everybody can hear us okay. The 2 of us are on a speakerphone here, and we're also hoping the weather holds off. We're under a tornado watch. If you lose us, we'll dial in on our cell phones, I guess. So, but anyway, we're really honored to be here. We're just regular family physicians in Murfreesboro, Tennessee. We're in a practice that has 3 sites. There are a total of 4 physicians. And we're basically connected by the Internet and Practice Partner.
We want to tell you a story today about how we transformed our practice, tell you what we had done before TransferMed and how TransferMed helped us, how they accelerated our progress and gave us momentum that continues to this day. We want to look back and see how we see the patient-centered medical home now 4 years after TransferMed.
Oh, one thing I did want to mention is that while we're going through this talk, be thinking of your own practices, experiences, where you've been, where you are now, where you want to go. Also think of the specific areas you want to work on, and I'm assuming we may have some providers on the line, we may have some office managers, maybe some other people, but we're sort of speaking more from the point of view of physician leaders in our practice. This is where we were in 2000. Our hospital divested itself of its physicians then. Of course, they're hiring them again now, but they divested then, and we found a couple of other like-minded physicians and basically began our journey.
We worked as doctors. We stumbled on decisions as they came up, and we tended to opt for the memorable over the average, but we didn't do it in any systematic way.
So basically, this is our path from the year 2000. That's sort of when we started making some different kinds of decisions. We'd basically been very routine, traditional practices up to that point.
But when she developed this diagram, I looked at it and said, well, gosh, that isn't how it was. The story was more complex than that. Another diagram might be better. And so I tried to draw one showing the different starting points in quality and time, showing how the progress wasn't smooth and how there were setbacks and surges in progress. But how could you tell a story with a diagram like that? So we went back to the original idea.
So, yeah, basically, I think Randy had the right idea, and you all can probably imagine things going on in your practice where you've got like 8 different projects, some of them doing well, some of them not, starting and stopping at different times. That's really a good picture of our journey, but we're going to go back to this way. We made a huge decision in 2000 when we opened our practice. We decided to get an EHR, and after searching, we ended up getting Practice Partners and implemented it. We did a pretty good job with and had a robust implementation. One of the things I can look back and see, though, is that I did way too much of it just myself, and over the years, with the help of PPRNet and TransferMed, we've learned how important team is and how important it is to build other leaders. In 2003, we started working on quality, and I want to tell you a little bit about what we brought to TransferMed. And TransferMed is one of the programs that Tim was telling you about that's available to you. Before we started on the journey with TransferMed, we had some assets. We had a Practice Partner, and it looks like, let's see if I can make this work right or not. Okay, there we go. We had Practice Partner. We already had PPRNet, and as you can see, we were having some success with quality there. We had just implemented a website and had WebView set up, the portal. We also brought to TransferMed people, and we did have some issues with our people, but we also brought some strong people to TransferMed. So here we are in 2006, and I don't know if any of you guys have heard of Trip Brad, but Trip is one of the real power users in Practice Partner, and he's the one who set up the EMR Village. He shot out an email to a bunch of us and said that the American Academy of Family Physicians had started a program that would help practices become the practice of the future. It was a national demonstration project. I checked with my partners. They were willing to go along, probably because they'd had some experience with PPRNet. So we filled out the application, and were fortunate enough to be chosen to be in TransferMed.
So we entered TransferMed, and what was it like? What did it do for us? Well, first of all, there was a vision. The vision it provided us, a vision of the future of best practice in primary care. This came to be known as the patient-centered medical home. This wheel is busy, but it embodies the vision. The detail it organizes serves as a checklist of the best efforts and the best practice. It's a place to look to see where you fall short in your practice and where there might be a gap that you can use to set goals for improvement.
And one of the things I really like about this diagram is what's in the middle. You've got the patient and you've got your team. Two of the bullet points here, or the little areas, are health information technology and your team. And to me, those two are the critical key tools for a patient-centered medical home. If you don't have a strong EHR and technology and you don't have a healthy team, you're going to be frustrated in any attempt you make to build your patient-centered medical home. I'm going to talk a little bit about each of these areas in more detail in just a minute.
Well, what did TransferMed do for us? Well, they put us in contact with a community of learners. The community of learners that exposed us to new ideas. Our peers and experts in their fields put us in touch with individuals who are skilled in promoting change. They gathered data. Patient satisfaction survey was done. Cycle times were measured. They made observations, active interviewing, and simple observations of both patients and staff. They observed workflow. They encouraged us to observe ourselves and assembled all this data. They compared these findings to benchmarks to identify gaps, opportunities for us to change. And once we found the gaps, we brainstorm on how to close them. They provided and encouraged creativity in addressing the gaps, and they helped us muster courage to deal with the obstacles and challenges. They helped us organize the change and understand the chaos of change. They converted practicing doctors into leaders of teams and taught us high-functioning teams. They helped build leaders within the teams. They encouraged everyone to work at the top of their license, and that benefited everybody. We ended up with new staff who were more able and more nimble in the team concept. They challenged us to do new things. They challenged us to do group visits, which we still do because they're valuable, and then e-visits, which we don't do as many of. They gave us both encouragement and direct advice, such as what to do with an employee who was not exactly in agreement with new team roles. They provided us with that community of peers where we could teach and learn from each other. They helped us understand ourselves and grow as leaders of our team. They gave us energy, direction, goals, new skills.
Randy, that's a good summary of what TransferMed did for us, and I think that even the new virtual TransferMed can add a lot of this for practices. One of the bullets or areas of a patient-centered